talking about post-transplant fungal infections. Vilesh, I'm audible, right?
Yes, sir. You can go ahead, sir.
Okay. So we know that over the years, organ transplantation has had significant good outcomes after better understanding of the immunology of transplant and newer immunosuppressions. And we were able to reduce the rates of rejection to satisfactory levels, but at the cost of increasing infections, especially bacterial, viral, and fungal, and some protozoal. So our topic today is invasive fungal infections. As we all know that it's a major cause of morbidity and mortality in this population of patients. So the maintenance immunosuppression mainly targets the T cells. As we know, the calcineurin inhibitors inhibit the calcineurin-induced upregulation of IL-2 expression, resulting in increased susceptibility to invasive fungal infections. Now, what is the importance of invasive fungal infections? As you can see in this slide, those who develop fungal infection after a transplant, an invasive fungal infection will have a mortality ranging from 25 to 80%. And once it comes to lung transplantation, we all know that more than 60% of the lung transplant recipients are infected with invasive aspergillosis. Now, this is the fungus perspective of the timeline of infection after transplantation. We can see that the fungus can affect a recipient at any stage. Maybe early period, the first 1 month, it is most commonly the candida that starts in the first month. When we go to the late period from the first month, from candida, we have aspergillus, mucor, and other endemic mycosis. And when we come to the very late period after 6 months of transplant, again, apart from these, you have the cryptococcus also coming. So this is the timeline of how the fungal infections happen. So this Transplant is one of the biggest study of infections in post-transplant patients. And we can see that it has studied around 17,000 patients, and 50% of which is the kidney transplant recipients. And when we see the Transplant study focused on the invasive fungal infections, more than 50% of the invasive fungal infections are due to invasive candidiasis, and around 20% is by aspergillus, and then comes cryptococcus that comes to around 10%. Also, the time of onset of infection is important, as demonstrated earlier in the timeline. Candida comes first, followed by aspergillus, and then cryptococcus. Now, I'll just briefly go to a case and a question for the postgraduates. I don't know if they're there. So, this is a 30-year-old male who underwent 1 month of hemodialysis prior to transplantation that was done somewhere around December 2013 with a sister as donor, haploidentical, and D plus R minus immune status for CMV. And he received the Similac induction and standard triple immunosuppression with valganciclovir prophylaxis. First 4 months or so, everything was fine with the normal graft function, and except for a NODAT for which he was on OHA. Then at 4 months, he started having low to moderate grade fever without any localizing signs. And investigations were also unremarkable except for a mild leukopenia. Because of that, MMF was reduced. Valganciclovir was stopped temporarily, suspecting viral infection, and with symptomatic treatment, he became febrile and he went home. And again, next month, he again came back with fever, and this time he had a persistent fever with abdominal pain, cough, and loss of appetite. And there was significant weight loss, 7 to 8 kilograms of weight loss. And investigations this time, that was 5 months post-transplant, showed a significant leukopenia, total count of 2,600, a graft dysfunction, creatinine 2.2, TAC level of 10, and some transaminitis and increased gamma GT. CMV was negative, and his weight had significantly reduced. Now he was started on broad spectrum IV antibiotics due to leukopenia, MMF, and Valgan cyclovirus stopped, and sputumescent for lab staining, FD, and potassium KOH stain. X-ray was unremarkable, and ultrasound was normal. And we went ahead with an HRCT chest. As you can see in the HRCT chest, there was a subsegmental consolidation in the right surrounding ground glass opacity and few nodular opacities. So fever over a month's duration, leukopenia, deranged LFT, graft dysfunction, consolidation with pulmonary nodules on CT, weight loss and sputum being negative. We went ahead with the bronchoscopy and the bronchoalveolar lavage, and that showed this branching septate hyphae resembling aspergillosis. The bile sample was sent for culture, which grew aspergillus over a period of 3 weeks. So the final diagnosis was invasive pulmonary aspergillosis, and he was treated with oral voriconazole and improved. Now the question is, which of the following is correct about pulmonary aspergillosis in solid organ transplantation? The choices are A, serum galactomannan test is a sensitive test for diagnosis of invasive aspergillosis. Culture of respiratory secretion is usually positive in early stages of the disease. Multiplex PCR is a gold standard for diagnosis. Presence of a nodule in early post-transplant period in CT is highly suggestive of pulmonary aspergillosis. Anyway, we will keep this question on board and continue with the presentation. So I will be discussing two invasive funguses today. One is Candida and second is Aspergillus. Candida, as you know, as we have seen in the Transplant study, Candida is most frequent infective fungal disease, invasive fungal disease in the transplant recipient, and it accounts for half of all cases in this population. And its incidence is around 2%. And this candidal, invasive Candida is particularly high in abdominal solid organ transplants like intestinal, pancreatic, and liver transplantation. The clinical presentation are all familiar. We have the oral and mucocutaneous candidiasis. Esophageal candidiasis usually presents with dysphagia, odynophagia, and chest pain. Peritonitis is more commonly seen after liver and pancreatic transplantation. Candidemia is often associated with the central venous catheter. Candiduria usually represents a colonization or when you have an instrumentation of the urinary tract, like an indwelling catheter. But it may be a sign of disseminated disease in the kidney. Now, we should also consider the possibility of disseminated candidiasis, where patient presents with fever that is unresponsive to broad spectrum antimicrobials and associated usually with the prolonged intravascular catheters. And these patients usually have multi-organ failure. Macronodular skin lesions are seen in 10 to 20%, and candidal ophthalmitis is seen in 10 to 20%. And usually patients can have coexistent other bacterial and fungal infections, and they may present with septic shock. Now, coming to the treatment of invasive candidal infection, it is recommended to start echinocandins as a primary treatment for severe invasive candidiasis, either caspofungin, micafungin, or anapilofungin. Other options include fluconazole, liposomal amphotericin B, or voriconazole. And once it comes to the consolidation phase, we can either convert to fluconazole if the strain is fluconazole sensitive, or voriconazole, especially when you have a fluconazole resistant non-albicans varieties like Candida krusei and glabrata. So the duration of treatment for Candida is at least 2 weeks after the symptoms subsides and the culture is negative. Now, going on to aspergillus, the incidence of aspergillus, invasive aspergillosis, is 0.1 to 2.4%. And as I've told earlier, the incidence is higher in lung transplant recipients. The most common form of invasive aspergillosis is an invasive pulmonary disease, which usually presents as an acute invasive pulmonary disease. So you can have a tracheobronchitis that has a mortality of 25% and an invasive pulmonary disease that has a mortality of 80%. So clinical presentation, we know that this aspergillus is a ubiquitous fungus. It is present everywhere. Contamination in the upper airway, colonization is common, and it is being stored in the ACs and other places. And once it becomes aggressive or invasive, it can cause tracheobronchitis, and then it can progress to aspergillosis, pulmonary aspergillosis, and then ultimately it can disseminate the form of disseminated disease. Now, as far as the kidney transplantation is concerned, Aspergillus fumigatus is the most common species causing invasive aspergillosis, and the risk factors are high dose and prolonged corticosteroids, requirement of dialysis, and total immunosuppression, especially anti-rejection. Renal transplant recipients usually present with vague clinical symptoms of infections, and early laboratory findings are normal, as in the index case. To improve the prognosis, a high index of suspicion is necessary in these patients. Unexplained fever, despite broad spectrum antibiotics, for more than 3 to 6 weeks, recurrent febrile episodes after the initial effervescence, and the presence of pulmonary infiltrates during antibiotic therapy can indicate a fungal infection. Early symptoms of invasive pulmonary aspergillosis include cough, fever, and hemoptysis. Now, this slide shows the various incidents of invasive aspergillosis. As you can see, 10% in stem cell transplantation, lung transplantation is around 15%, and kidney transplantation is 1%, and the mortality is around 60% in kidney transplantation. Treatment of invasive aspergillosis, the drug of choice is voriconazole. The patient is unstable. You can start with IV voriconazole at a dose of 6 milligram per kilogram twice a day for 2 doses, followed by 4 milligram per kilogram, and shift on to oral once patient is stable. Other option is the liposomal amyloidosis. Same thing, you have to continue 2 weeks, at least 2 weeks after the symptoms subside. Now, coming to the recommendations for diagnosis. Basically, the diagnosis of invasive fungal infection lies on the culture, detection of antigens, radiological findings, and also antibodies are there for some. So, positive blood cultures that yield yeast or in some cases filamentous fungi are considered diagnostic of invasive fungal disease. A proven diagnosis of invasive fungal disease can also be based on observation of tissue histology for invasive fungal structures or through isolation from sterile tissues or fluid samples. Now, this beta-D-glucan is a polysaccharide. Quantification is recommended in serum for ruling out candida infection in adults with the risk factors and symptoms suggestive of invasive fungal infections. Detection of glucomannan antigen in plasma or serum should not be used as a routine diagnosis or treatment of invasive aspergillosis in transplant patients. But detection of glucomannan antigen in BAL or CSF may be useful in the diagnosis of invasive aspergillosis and should be performed whenever possible. Now, coming to the prophylaxis, because this is an infection that has high mortality, especially in the abdominal transplantation, in pancreatic transplantation with the risk factor of enteric drainage, vascular graft, or post-perfusion pancreatitis. For candida, prophylaxis with fluconazole or liposomal amphotericin B is recommended for more than 4 weeks, and small bowel transplantation with these risk factors, fluconazole or amphotericin B is being recommended for at least 4 weeks. When we come to aspergillus, the recommendation for prophylaxis is for liver transplantation as well as for lung transplantation. And for these high-risk patients, you have liposomal amphotericin B or voriconazole to be given for 4 weeks until the resolution of the risk factors. And for lung transplantation, you can either give inhaled amphotericin B that has less of toxicity, or voriconazole or voriconazole that is to be given 2 weeks to lifelong. So that is one thing that is to be kept in mind. Now, this slide shows the various options of treatment in invasive fungal infections, which I just mentioned. For Candida, it's fluconazole and caspofungins that comes in the list, followed by amphotericin. For invasive aspergillosis, the drug of choice I told you is voriconazole. But again, other drugs include the echinocandins. And cryptococcus again, fluconazole and liposomal amphotericin B. For other invasive fungal infections, again, it's voriconazole that's coming up with this. So, before I end the topic, I'll go back to the question: which one of the following is correct about invasive pulmonary aspergillosis? Serum galactomannan test is a sensitive test for diagnosis of invasive aspergillosis. Culture of respiratory secretion is usually positive in early stages of the disease. Multiplex PCR is the gold standard for diagnosis. And presence of a nodule in early post-transplant period in CT is highly suggestive of aspergillosis. So culture of the respiratory tract secretions is not very sensitive, and it is positive at late stages of the disease. Serum galactomannan assay is not very sensitive in solid organ transplantation, but in bowel secretions and CSF it is sensitive. Radiology halo sign may be seen, but it is not sensitive. The answer is presence of nodule, as we have seen in this patient, in early post-transplant period in CT is highly suggestive of pulmonary aspergillosis. So that is the answer to the question. And multiple PCR is now developed, but needs further validation. So to summarize, invasive fungal infections is a major cause of morbidity and mortality among organ transplant recipients. The incidence of invasive fungal disease varies depending upon the type of transplant and the degree of immunosuppression. The most common fungal pathogen causing invasive fungal disease in transplant recipients include Candida and Aspergillus. However, the incidence of non-Aspergillus moths like Zygomycetes and Fusarium species have been increasingly seen now. The diagnosis of invasive fungal disease in transplant recipients can be challenging, and a combination of clinical, radiological, and biological findings is often necessary. Treatment typically involves antifungal medication, but prevention through close monitoring, prophylactic measures, as well as minimizing immunosuppression are the other key points in minimizing the risk of infection. So, thank you. That ends my talk.